Good afternoon, ladies and gentlemen. We are back with the second session of our three-part educational webinar series on advancing diagnostics, evolution, and hematopathology. This is being brought to you by Unipath Speciality Laboratory and Vanguard Diagnostics, which is an R&D and manufacturing company in the in vitro diagnostic space. We are extremely grateful to you for engaging so actively in this webinar series. My name is Veena Kohli. I'm the CEO and founder of Vanguard Diagnostics, and it's my pleasure to invite and welcome each one of you to the second edition of this very special webinar series titled Peripheral Blood Demystified. The subject of peripheral blood is so vast and vital that in order to do full justice to the topic, we decided to bring it to you in two parts. The first part is being presented today, and the second one will be presented on Wednesday, 15th of May, next month. Today's session will be moderated by none other than Dr. Ravi Gaur. Dr. Ravi Gaur is the chairman of the Medical Advisory Committee at Unipath Speciality Labs and is the founder of DRG Labs. We all know that Dr. Gaur is a renowned oncopathologist, and he has 30 plus years of experience in pathology, immunology, molecular diagnostics, and genomics. And he's very passionate about steering the course of diagnostics towards personalized medicine and emerging technologies. Ladies and gentlemen, we are extremely fortunate today to have another opportunity to learn from the guru of hematopathology, Dr. Tejinder Singh, as he elucidates the enigma of peripheral blood. Dr. Singh brings with him 40 plus years of diagnostics experience and wisdom. And we all know that books authored by him have shaped the curriculum of medical education in India. So stay tuned as our experts share their insights on the intriguing and important subject of peripheral blood. So it's over to you, Dr. Gaur.
Good afternoon, Inaji, and good afternoon, sir. It's my pleasure again to be here with you in FED, probably, listening to you. Probably I'll be just doing an introduction, and after that, I want to hear you more and more. So it's a pleasure again, and welcome to this webinar series. And I thank Veena Kohli ji because for this Vanguard for bringing this scientific seminar. And of course, my Unipath Speciality Laboratory putting together, enlightening the people, and so many things we need to work probably every day in fit. Whether when we are working in our life in pathology lab, we find something new. In any case, when the teacher is like you, I think every day, every time we hear from you, we find something new also. That's still learning going on. Thank you, everyone, and I think I look forward for this this good session. This is basically a part of Advancing Diagnostic Evolution Hematopathology webinar series brought by Vanguard and Unipath Speciality. Welcome everybody on their behalf. As already mentioned, today we are talking about peripheral blood demystified part 1. And part 2 will be on 15th of May. So it's although I don't need to really introduce Dr. Tejinder Singh, sir, I think, I think I can probably only say, if somebody has to ask me to introduce you, I probably say, you're the greatest teacher, don't just impact knowledge. They illuminate paths, humbly guiding others to their own discoveries and quietly light the way of others to shine. That's probably your introduction is. We all look forward for your knowledge. We look forward everything from whatever and fit. Of course, formally, sir has been like whenever it comes to hematopathology, I think it's synonymous with wherever it is. He has been started his innings as the Maradona Medical College, the director, HOD, and beyond. And every institution of hematopathology or hepatology, he has been heading that. And it's my pleasure to have you here with us in our organization, sir. And I think I'm blessed to have you here. And again, the session. So with that, I'll start this session probably, I think, I'll take one or more minutes before we hand over the mics to you. A peripheral blood smear is a diagnostic test, you know what they say, and where a drop of blood is spread thinly into glass slide. Small drop of blood, stained, examined under a microscope, and it's used to evaluate the different types of blood cells, RBCs, the white blood cells, platelets, for abnormality for infection, anemia, leukemia, and much beyond. So much information for a very small drop of blood. That's the smear provides for the size, shape, quantity, the quantity of blood cells, aiding in diagnosis and monitoring the various medical conditions. That's what I'm saying. Within the simplicity of drop lies the complexity of life unraveled. That's exactly what we see. It is in this seemingly simple test that most valuable insights can be found, offering a window into the inner workings of our body. While the process may appear very straightforward, it is subtle intricacies that make it both challenging and immensely informative. Peripheral blood examination, despite its outward appearance of simplicity, interpreting peripheral blood samples require a meticulous eye and a detailed oriented mind. I think that's it. I'd like to hand over to you, sir. Please take it forward. We are looking forward to hear you and probably gain something much more again today. Thank you, sir, and thank you, Inaji. Sir, please take it over. I'd like to add one more thing. Anybody have any questions, please put that in a chat box and we'll try to answer at the end of the session. And meanwhile, I think please enjoy the talk and I think let's attend to discussion. Sir, please.
Thank you, Dr. Gaur. Thank you, Dr. Veena. And thanks to every participant. It is my pleasure to be here and discuss with you and interact with you on the simplest test in the hematopathology, that is the peripheral blood film. And today I'll be covering the red cells. The white cells and platelets we'll be doing next time. See, we all know in my first lecture, I told you about the discovery of the red cells, which was by Leeuwenhoek sometime in 17th century. Now that was followed by Ehrlichs, who devised a stain which would stain the nuclei of the white cells. And there started the hematology. And then in 1934, anemias were classified by Winthrop on the basis of the red cell size. And that is where the concept of normocytic, microcytic, and the macrocytic picture came. And then finally in 1950, the automation started. Coulter invented the cell counter based on the size of the particles. That means based on the size of the platelets, the white cells, and the red cells. And then there have been tremendous advances in cell counter technology. And now we have 3-part differential counters, 5-part differential counters. We have systems where the reticulocyte count is carried out, where the immature white cells, the band forms, the metamyelocytes, and now we have systems which pick up even the abnormal cells, whether the blast cells or the reactive lymphocytes. So the technology is increasing every day. However, we find that some of the tests which we used to do, like TLC and the platelet count, we used to do manual with a newer chamber, now have stopped. What we all have are automated systems. And in these automated systems, the TLC, the platelet counts are carried out very, very accurately. And moreover, since the large amount of blood is used in these cell counters, large amount, what I mean is, as compared to a peripheral smear, amount of blood used is not much. Rather, in even children also, we can use these cell counters for effective cell counts, both platelets, white cell counts, as well as the red cell counts. However, cell counters are very good for counting. They're perfect at that. But if there is an alteration in the morphology of the red cells, white cells, or platelets, it may not be able to pick up. As I can show you here, there are 4 smears. In the first smear, what you find, the larger cells are the normal cells. And then we have the smaller cells. The smaller cells are darker cells. They are spherocytes. Now, these cell counters cannot differentiate between the normal red cells and the spherocytes. Then on the right, we have again normal red cells, and then these are the target cells. It cannot differentiate that how many are target cells and how many of them are normal red cells. So that means, and here we find below the purple slide, what we find is stomatocytes. Now we'll be discussing later on what stomatocytes are. Cannot be picked up. Similarly, here we have elliptocytes. Now these are all diseases of blood. Rather, these are different types of anemia, like hereditary spherocytosis, like we have sickle cell disease with a large number of target cells, hereditary stomatocytosis, hereditary elliptocytosis. If we do not examine the peripheral smear, we just rely upon the cell counter, most probably we will be missing all these diseases. And that is where lies the mystery of a peripheral blood film. We talked about the bone marrow in last 2 lectures. I told you that we should report always a bone marrow when we have the clinical data and we also have the peripheral blood, because the peripheral blood will reflect what is going on in the marrow. And what is going on in the marrow is, if the disease has started in the body, is it involving all systems? Is it involving one system or 2 systems? That is reflected on the bone marrow. Bone marrow tries to remove the disease by producing more and more cells. And as a result of which, that is reflected in the peripheral blood. Either the white cells go up, the white cells go down, or the platelets increase, or it is a reactive change. And that is where the mystery of a red cell film is there. I had a case, 80-year-old lady, she had jaundice. She has been under treatment for last 30 years, but no final diagnosis was made. She has low-grade fever and jaundice. The diagnosis could not be made. Liver biopsy had been done. And however, we saw some reports, but we were not convinced about the peripheral blood film. Bone marrow had been done, which showed only the erythroid hyperplasia. So we saw the liver biopsy, which had already been done. And what did it show? It showed hemosiderin pigment inside the liver cells, that is the parenchymal, as well as few particles were seen in the macrophages. Now, there are very few diseases in which we find the hemosiderin accumulating inside the liver parenchyma cells. One is hemochromatosis, and then hereditary spherocytosis, in which we find it is both in the reticuloendothelial cells as well as in the parenchymal cells. We asked for a peripheral smear. And what would we find in the peripheral smear? Peripheral smear showed spherocytes. We examined the smears of her sons. They also showed spherocytes. We examined her grandsons, grandchildren. All of them showed there were spherocytes in the peripheral blood. So that lady has been suffering from hereditary spherocytosis all these years. She has developed jaundice. That is again because of hereditary spherocytosis, it being a hemolytic anemia. So a diagnosis of spherocytosis could be made on a simple test, that is the peripheral blood film or a peripheral smear. So where do we use peripheral blood? Number 1, for screening. Number 2, for diagnosis, and then monitoring of the disease, especially many of the hematologic diseases or inflammatory diseases or infective disease, where we find the counts go up, and then we keep on monitoring. As we give the antibiotics, the counts start coming down, and we keep on monitoring, and then for therapeutic response. So there have been tremendous advances in hematology, but the diagnostic relevance of the peripheral blood film has not lessened in any way. It still holds its head high, and the peripheral blood film will always be used in times to come to pick up the disease process. Now that gradually we'll go up today on the red cells, and then we will go on to the white cells and the platelets. Not only that, The peripheral blood morphology is a core skill of the practicing hematologist, and that plays a key role in their ability to provide a timely diagnosis. I remember over the years we have been reporting APML, M3, whether it is a variant type or it is a hypergranular type. We see the smear, find the atypical cells, think that these are probably the promyelocytes. Look at the red cells. If there any fragmentation is also occurring, if the DIC is occurring, the platelets are diminished. Nobody waits for PML RARA. We just inform the clinician that it is a picture of M3. You can do a myeloperoxidase. So the rapid treatment has started, just a look at the peripheral smear and the patient is under treatment. On the other hand, of course, PML RARA has its own value, but the treatment starts with a simple examination of a simplest peripheral smear. Now, this is a window. This is the bone marrow. What you find that in the bone marrow, there is a window. So peripheral smear is a window to the functional status of the bone marrow. Whatever goes on in the bone marrow is reflected in the peripheral smear. Now, human eye, it is believed, can detect subtle changes in the blood cells which cannot be picked up by the cell counters. And here lies the significance of evaluation of a peripheral smear. So to sum up, it is used to diagnose a disease, monitor the response, correlate the instrument flag, and then whatever additional information it can provide. So what do we do? What I'm going to do today is discuss about the RBC morphology, then WBC morphology, platelet morphology, hemoparasites, artifacts, and troubleshooting. Now, this is the smear. This is a peripheral blood film, which is made from a drop of blood. And these are nice smears which have been made. What you find here is a thin part of the smear. This is the head part of the smear. This is the tail part of the smear. Now, the basic difference these two smears is you find that this is a very dark smear as compared to this one. Now, there could be two reasons. First is that the hemoglobin of the person is pretty high. As a result of which, what has happened is that too many red cells, the smear is slightly thick and you find that it is a dark staining. Second is that if the right stain or a Giemsa stain, whatever we are using, the pH is not proper. If the pH is alkaline, as could have happened in this case, alkaline pH will make the smear blue or gray in color. On the other hand, if the pH is acidic, more than pH 6.8, then what happens is that the whole smear becomes red in color. So therefore, pH of the stain is very, very important to get the adequate and optimum morphology. Now, this is a drop of blood from which we make the smear. Now, where do we examine? Because we have got head, we have got the tail of the smear. Now, this is the area we just forget about the tail. If we have to look at the morphology, we do not examine the tail. Then when do we examine the tail? Why should we examine the tail at all? See, the platelets, they move towards the tail. Second thing, any cell which is heavy, that means heavier than the red cells, will move towards the tail. So which cells move to the tail? You will find the neutrophils will come to the tail. Those are the ones. The malarial parasitized red cells are heavier than the rest of the red cells. They will also move towards the tail. So you must have seen that some experienced pathologists, they put the slide under the microscope and say MP is positive, while somebody else has spent about 1 hour looking for a malarial parasite, he didn't find. So what has that pathologist done? He has straight away gone to the tail because he knows that the red cells which are parasitized are heavy. So he looked at the tail, he found 1 or 2 malarial parasite and the diagnosis is made. So this is so one has to look in this area just next to the tail and also at the tail. Another case, what happens is that sometimes we find, examine the smear, that there is leukopenia. If there is leukopenia, you must examine the tail. Why? Because if there is leukopenia, all the cells might have come to the tail, resulting in leukopenia in rest of the smear. So leukopenia could give rise to lack of cells in rest of the smears and hence the need. Now this is the tail. What you can see here, the two neutrophils, and here the red cells are lying very close to each other, and these are the neutrophils which have come to the tail. The malarial parasites being heavy also come in this area. Now this appears to be a rouleau formation, but actually this is not rouleau. This is a thicker part of the smear. That means it is at the base of the smear or head of the smear where you find, normally you will find this picture. Another example is that we should always examine, like I said, for the bone marrow, first examine under scanner, low power, high power, and then oil immersion. Now what happens? This is low power. What I'm finding here is fibrin material is there. And this fibrin material has entangled many white cells. So we may not find white cells in rest of the smear where we are going to do the count. Similarly, here you find there are platelet clumps, huge platelet clumps, which have again come to the tail. Now, if you examine under low power, you will be able to see the clumps, you will be able to see the fibrin strand. If straight away you go to the oil immersion, you will be looking at the red cells only, and you will miss that the platelets are normal. Then we go to the high power. High power is 40x. It gives us a rough idea about the THC. Is it high? Is it very low? And then we can count the number of platelets in these smears if these are made from the EDTA blood. And finally, in oil immersion, actual morphology of the malarial parasite, the actual nucleoli, the open chromatin, coarse chromatin of the cells is appreciated in oil immersion. So any smear, you should always examine oil immersion, both the red cells and the white cells, to see if we are talking about the reactive lymphocytes, or we are talking about the blast cells, or we are talking about the plasmacytoid cells. Now, what do we assess in the red cells? Size, number one, normocytic, microcytic, macrocytic. Are the cells similar in shape and size? Anisocytosis. Shape, are there any teardrop cells? Are there any elliptical cells? Are there any fragmented cells? That means the poikilocytes are present. So anisocytosis, poikilocytosis. And then we look at the relative hemoglobin content. That will be going along as we go into hypochromic anemias, that if there is hypochromia is more or they are normochromic. Polychromatophilia. Now, polychromatophils are actually the reticulocytes. They are also heavy. So where do they go? They will also go to the tail of the smear. So always look at the tail and look for polychromatophils. Rouleau formation or agglutination. Now, rouleau formation is very, very important because whenever there is hyper gamma globulinemia or there is increase in fibrinogen, you will find that there will be rouleau formation. Now, and these are the cases in which the ESR is high. Because the rouleaux are formed, they become heavy and they fall very rapidly, resulting in a high ESR. Are there agglutinates? Agglutinates are something like when we were doing blood grouping as an undergraduate student, you add NTA to the A cells, you will find the big clumps, agglutinates of the red cells are formed. Is there a rouleau formation in the smear? Is there any agglutination? And then in oil immersion, what we are looking at are inclusions in the red cells like Howell-Jolly body, stippling, Cabot ring, and so on. Now, which disorders are we going to see? Basically, we are, because of one of the major group of disorders of the red cells are anemias. That means the number of red cells comes down, hemoglobin comes down from 15 grams to anything about, we have seen as low as 2 grams also. So the anemias is a major group, and anemia is prevalent all over the world. And of course, in our country, we find deficiency anemias are much more common. Then we have red cell enzymopathies. That means G6PD deficiency. Yes, it is quite common in our country. PK deficiency, pyruvate kinase deficiency, is not as common. Then we have P5N deficiency. I'll demonstrate to you how does the red cell look like in that condition. Then red cell membrane disorders, spherocytosis. hereditary spherocytosis, where you find the red cells are not biconcave disc, rather those are spheres. So hereditary spherocytosis. Then we have hemoglobinopathies. We come across so many hemoglobinopathies in our countries, which includes thalassemias, sickle cell disease, hemoglobin E disease in the eastern part of the country, hemoglobin D disease in northern parts, especially in Punjab. Then we have cytoskeletal abnormalities and membranopathies. Now in membranopathies will come spherocytosis, ovelocytosis, elliptocytosis, xerocytosis, stomatocytosis. See, the idea of telling you all these is that these are the diseases which do affect the population. And these are not only just to give a table, but actually you come across all these lesions somewhere or the other. And then we have polycythemia vera, which is a condition which of course is a myeloproliferative neoplasm. This is one condition where you find that the red cells increase in number, and it is neoplastic proliferation. Unlike a relative polycythemia or a relative erythrocytosis, which may occur in certain conditions like dehydration. Winthrop was the first, I told you, to classify anemias based on the red cells size. Now now we have three types of main anemias based on morphology. Smaller red cells, microcytic hypochromic. Normal size, normocytic, normochromic. Now that occurs whenever there is acute blood loss, chronic disease, aplastic anemia, and some of the hemolytic anemias, you will find normocytic, normochromic. Macrocytic anemias, all of you know very well that it is due to folic acid and vitamin B12 deficiency, but they result in a megaloblastic anemia. Then we have macrocytic anemias with normoblasts present in the bone marrow, unlike megaloblasts. So based on this, what is it based on? Now we have cell counters. Now the cell counters decide microcytic, normocytic, macrocytic by counting a large number of red cells and then giving an average. What is the volume? Say in macro, the volume, normal volume is about 90, 85 to 95. But in macrocytic, it is more. That is more than 100. Normocytic is 80 to 100, where we take average as 90. And then we have microcytic anemias, where we have less than 80. So based on the size, that is based on the MCV, and MCH and MCHC give us an idea about the hemoglobin content in these macrocytic, normocytic, and microcytic anemias. Now, microcytic hypochromic anemias are not only deficiency anemias like iron deficiency anemias or thalassemias. Few cases of sickle cell anemia will also show us a microcytic hypochromic picture. Hemoglobin E disease will also show us a microcytic hypochromic picture. So what we have to do is to differentiate one from the other by carrying out further tests. Further tests may include hemoglobin electrophoresis, which we used to do first on the filter paper, then on the cellulose acetate, and then we started doing on DEAE Cephadex. Then we went on to column chromatography, where we used DEAE cellulose, and now we have the HPLC. And the capillary electrophoresis. Now these are very good instruments, and they pick up small amounts of abnormal hemoglobin, and based on that, now we know the exact incidence of thalassemia trait, where we find that the hemoglobin A2 is beyond 3.5. It is usually between 4 and 8%. Now, this is just to tell you the shape of the red cells as differentiated from a normal red cell. Say this is a normal red cell, this is the size, there is a central 1/3 pallor. Now below this, cell is smaller, that you can see, but the central pallor remains the same 1/3. Then we have the macrocyte. Macro is larger red cell, but it is round, same round as we find the normal red cell. Now, such a macrocyte we come across are the polychromatophores or the reticulocytes. The reticulocytes are macrocytes. They are not oval. Now, what about this oval macrocyte? Oval macrocytosis is a feature of macrocytic anemia due to folic acid and B12 deficiency. That is a condition you find oval macrocytosis. And then we have the hypochromic macrocytes also. Again, here we have the target cell where you find the hemoglobin. There is a central blob of hemoglobin, and then at the periphery. Spherocyte I showed you earlier. This is the ovalocyte. The shape of the red cell is oval. Stomatocyte. Now, how does a stomatocyte? Stoma. There is a mouth-like hypochromia in the center, which is longitudinal along the length. So such cells are known as stomatocyte. Sickle cells may be board-shaped cells or actually sickle cell. Acanthocytes you find on the surface of the red cells. There are few projections, and it is a thorny red cell, but these projections are not evenly distributed. Why I'm saying not evenly distributed is because this is to differentiate acanthocytes from the burr cell at the bottom. You find burr cells where you find the raised projections or the thorn-like projections are uniform and they're blunt, while here these are sharp. Now, this is acanthocytes are seen in neuroacanthocytosis. These are seen in PK deficiency. Then we have the fragmented or the schistocytes, where these red cells, they break down. Different shapes and sizes, maybe hat-shaped cells, and these are very sharp edges these have got. Teardrop cells, as the name indicates, actually you do come across teardrop cells whenever you find there is fibrosis in the marrow. Now, this fibrosis may be part of the disease process, may be a case of primary myelofibrosis, or the fibrosis may occur as a result of metastatic deposit in the bone marrow. Now, what about, see, this part is normal. Here you find that central pallor is more than 1/3. So that means it is a hypochromia is more. Here it was nearly half. Here you find it is 2/3 is showing pallor. Next one, 3/4 is going a panel. Why? Here you find it is almost the whole red cell is showing pallor except for a small ring of hemoglobin at the periphery. What we call them as ring cells or pessary cells, especially in cases of iron deficiency anemia. So what we have talked about are generally the shape of the red cells, what we are looking at. And then we go on to the classifications. There are many classifications given. Very simple one I'm talking about, hereditary hemolytic anemia. And these are the acquired ones. Now, hereditary, we have spoken about the red cell membrane defects, the defects in the globin synthesis. Now, we all know that hemoglobin is made up of heme and globin. Whenever there is a defect in the globin synthesis, you find abnormal hemoglobin, hemoglobin D, hemoglobin E, hemoglobin S, hemoglobin C. All of them have defect in the globin synthesis. Then enzyme deficiencies, both pentose phosphate pathway as well as glycolytic pathway. The major one is G6PD deficiency, followed by pyruvate kinase deficiency. And then we have the red cell nucleotide metabolism is defective, that is P5N, pyrimidine 5 nucleotidase deficiency. Now, of the acquired ones, immunohemolytic anemias, what we call as Coombs positive anemia, autoimmune hemolytic anemias, fragmentation syndromes, PNH, drugs and chemicals. All over the world, we find that people take too many drugs and without knowing whether to take or not, as a result of which some of them result in hemolysis. Some of them, if taken by a G6PD deficient person, will result in severe hemolysis, thermal injury, and of course, the infections. Now, the hemolytic process. Now, what happens in hemolytic process? Hemolytic process is normal life of the red cell is 100 to 120 days. If this life of the red cell is shortened, that means it will be either sequestered in the spleen less than 100 days. That means by 50 days, by 40 days, by 30 days. The earlier it is sequestered, the earlier it is hemolyzed, the severe is the hemolytic anemia. Body tries to compensate. How does it compensate? It leads to a compensatory marrow regeneration. The marrow multiplies, the erythroid precursors are there, just full of erythroid precursors. Yet, the patient is anemic. Why is the patient then anemic? Because the marrow compensation is not adequate enough for the amount of anemia which has developed. And then what we find is, since the marrow is compensating, it is releasing immature red cells. Immature red cells are actually the reticulocytes. You can see the reticulocytes, the reticulocyte count increases. So to know whether it is a hemolytic process or it is a hypoproliferative process, what we call as hypoproliferative means the proliferation is less than normal. Such we call as bone marrow failure syndromes. In bone marrow failure syndromes, the reticulocyte count goes less than 1%. In hemolytic process, you will find the reticulocyte count goes up. So there is in hemolytic anemias, morphologic red cell changes. We will tell you what type of hemolytic anemia it is. There will be compensatory marrow regeneration. There will be a high reticulocyte count. Now, when we see reticulocyte, we have to make a preparation using brilliant crescent blue or by using new methylene blue. And if you examine the peripheral smear, what we find in the peripheral smear is these large cells. These large cells are polychromatophils. They're slightly purplish tinge. Why? Because they've got RNA. And how do we detect the RNA? That RNA we detect by doing the reticulocyte count fluid. That is new methylene blue or by using the brilliant crescent blue. So a peripheral smear has given me idea. Yes, the reticulocyte count is going to be high. And this, of course, sometimes the nucleated RBCs are also released into circulation early and you come across them. This is the two types of hemolytic process, extravascular and intravascular. Now, intravascular, you all know, PNH, all hemoglobinuria, paroxysmal nocturnal hemoglobinuria or cold hemoglobinuria. Compensatory mechanism, we have seen polychromasia, high reticulocyte count, and erythroid hyperplasia. Now, this is just to show you again the leptocytes, avelocytes, echinocytes, spherocyte, sickle cells, and acanthocytes. Now, hereditary spherocytosis, I'm not going into the details, but you should be aware of the fact that it is resulting in anemia, jaundice, splenomegaly, gallstones. Now, these are seen in children. Usually, children present when school going, usually at 10 to 15 years of age. And of course, undetected cases you may come across in young age. And we have come across even an 80 years old lady having hereditary spherocytosis. Some of these cases do develop aplastic crisis. What is aplastic crisis is they get infected with parvovirus B19, which causes pure red cell aplasia. That means the erythropoiesis completely stops. And what do we find in the bone marrow then? Giant proerythroblast. I'll show you a picture of a giant proerythroblast, and then you make a diagnosis that there is aplastic crisis. Now, this is a mimic. On the left, I can see that these are the spherocytes or microspherocytes. They are uniform in size. See here, in this film also there are spherocytes, but there is a difference in the size of these spherocytes. Some are really small, some are slightly bigger. Now, this variation in size is highly suggestive of autoimmune hemolytic anemia, while this one is highly suggestive of hereditary spherocytosis. Of course, we have to correlate with the clinical findings in both the cases, but this is a picture of autoimmune hemolytic anemia. So one simple test which can differentiate between the two is Coombs test. In autoimmune hemolytic anemia, Coombs test direct is positive, while in hereditary spherocytosis, it is negative. But here you find spherocytes in the peripheral smear of the family members. So that is autoimmune hemolytic anemia, and direct Coombs is positive. Other conditions where you come across spherocytes on the peripheral blood is hemolytic disease of the newborn, where there is a ABO incompatibility or RH incompatibility. And there you find that in hemolytic disease of the newborn, you will come across large number of nucleated RBCs are present after transfusion also, and sometimes in microangiopathic hemolytic anemia. So these are the red cell membrane disorders. What we have a little bit talked about is hereditary spherocytosis. Then we have the hereditary leptocytosis. Now, these are all autosomal dominant conditions, except for few cases of HS, which are autosomal recessive. Then we have the overhydration syndrome, that is a stomatocytosis. And then we have the poikilocytosis, pyropoikilocytosis, where you find that it may be a moderate to non-hemolytic process. Now, this is the leptocytosis. The red cells are elliptical, and there is a membrane defect. The membrane defect lies in the spectrin or ankyrin, giving this particular shape. Hemolysis is mild to moderate. Stomatocytes. Now, I showed you the stoma. It is the stoma. It is something like stoma or the mouth, and these are the red cells. Here again, the hemolysis is not severe. It is a mild to moderate hemolysis, and some cases may be even asymptomatic. Now, this is hereditary pyropoikilocytosis. Now, what is the difference between the two is that in leptocytosis, you find mainly uniform leptocytes, while in pyropoikilocytosis, you will find uniform leptocytes. In addition, you will find teardrop cells, and you will find evidence of fragmentation also. So that is pyropoikilocytosis, uncommon condition. Then we go on to the enzymopathies. Now, this is a smear from a 27-year-old doctor who complained of weakness of 4 days only. Hemoglobin 10, TLC slightly increased to 12,000, MCV, MCH normal. RDW was increased, 19.7. Platelet count normal. Retic is very high. Reticulocyte count was 11%. And this is a picture we got. Normocytic normochromic anemia and 11% reticulocyte. And what did this peripheral smear give us an idea? Number one, since the reticulocyte count is high, so we know that it is likely to be a case of hemolytic anemia. That is one. If hemolytic anemia, then which one? That was a question. So we examine the peripheral smear. What do we find? Spherocyte. And then you find this red cell that as if somebody has taken 2 bites out of this red cell, 2 bites out of this red cell, single bite. So what we are dealing with, single bite cell hemolytic anemia. And where do we find bite cell hemolytic anemia? Bite cells, spherocytes, then you find polychromasia, increased reticulocyte count. This is a feature of G6PD deficiency. Now, what had he done? This boy, why he went into hemolysis? This boy had taken Dapsone, and he had taken Dapsone for acne on the face. And as he took Dapsone is an oxidizing drug. And what did it lead to? It converted hemoglobin of the red cells into methemoglobin. This methemoglobin, you can see this blue picture, and it formed a Hans body. And this Hans body was nothing but the hemoglobin, and you find it came to the periphery of the red cells. Now, this is a reticulocyte precipitation. Now, this thing we could see only because we made the reticulocyte precipitation. Now, if you get it done in the cell counter, you miss all these findings of Hans body and so on. So this is Hans body. So what happens is, as these red cells, they go into the splenic circulation, spleen finds them abnormal. It takes a bite. The reticuloendothelial cells take a bite and remove the Hans body. As a result, you find there is formation of bite cells. So this was a patient. And then here you find that these are the red cells where there is a very, very pale area. So what has happened here is the splenic macrophages, they have pulled the Hans body out of it, leaving an area without hemoglobin and without membrane at a part. So creating what we call as blister cells or hemighost cells. So whenever you come across such a picture of white cells, hemighost cells, blister cells, or in retic preparation you come across Hans body, we know that we are dealing with a case where G6PD deficiency is there, and this such a person has been exposed to any drug which is oxidizing or to any chemicals like naphthalene balls. If children are exposed to naphthalene balls, which we use at homes in winters, and that smell can lead to even hemolysis in children. So it is an oxidant drug injury. Then we go to another enzymopathy. That is a 22-year-old tailor, young man, and he came, he says he gets tired. He can't stitch more than a shirt in a day while his father stitches 4 shirts in a day. He stitches only 1. I said, what about his brother? He says he is equally bad. So on examination, he was pale, spleen was palpable. So it was anemia. Hemoglobin 7.8, microcytic hypochromic anemia. Now, this is again an important cause of microcytic hypochromic anemia. I always say that whenever we get a smear, please put some oil, have a look at the cells. So what do we find here? Where the arrows are, these are stippled RBCs. 1/3 of his RBCs demonstrate stippling. So he had basophilic stippling. And whenever we see basophilic stippling, we remember only one drug, one chemical, and that is lead poisoning. So we kept on asking, is he exposed to lead? He says no. He lived in Old Delhi, where the pipes are pretty old. So we got the water sample, got it tested for lead. The lead levels were not high. They was little bit high, but not dangerous enough. So then we thought that it could be a case of P5N deficiency, pyrimidine 5 nucleotidase deficiency, for which we carried out the isopropanol test. And then we did the test on his whole family. His other brother, who was also getting tired and who could not stitch 4 shirts, he also had, and the test, isopropanol test, was positive. But the disease could be picked up on a peripheral smear. So this is the basophilic stippling you come across. Do we come across basophilic stippling in other conditions also? Yes. Megaloblastic anemia is the other condition, the common condition which we come across. The other being heavy metal poisoning, myelodysplastic syndromes, megaloblastic anemias, porphyrias, erythroleukemias, even thalassemia and dyserythropoietic hemolytic anemias will also lead to a basophilic stippling. So it is a very, very important finding in the red cells. Pyruvate kinase deficiency is comparatively less common. But what we find in the peripheral smear is that if you see carefully, you will find that there is presence of these acanthocytes. Now here you find there are sharp projections on the red cell surface. And these are not uniform size, unlike the Burr cells. And it gives a clue. And that clue is that presence of these cells, we should think of pyruvate kinase deficiency. Another problem is that PK deficiency is not a very severe disease. It is a mild to moderate disease. Unlike G6PD deficiency, which can lead to even severe hemoglobinuria, and it can lead to severe anemia, and sometimes it can lead to even renal shutdown. But here, usually the hemolysis is mild to moderate. Then we go on to the common diseases. Common disease in our country, of course, is microcytic hypochromic anemia. But then I told you that the classification is that one can have normocytic normochromic, macrocytic, microcytic hypochromic anemia. Now, these are from the cell counter, these 2 curves. Now, if you look at it very carefully, it is very, very important. It gives a lot of information. The red cell, of course, are microcytic hypochromic. And what do we find here? The red one is the normal. But these cells, the blue one is reflecting these cells. So where is the curve? The curve is to the left. Left means the MCV is low. That is one. Second thing is that the lower part or the base of this is very wide. It is quite wide. So what happens is that means there is wide variation in the size of the cells. So there is anisocytosis, there is also microcytosis, so the MCV is low. See, in comparison to the macrocytes, again the red curve is the normal. This orange thing is belonging to the macrocytes. Now, since these are macrocytes, you find that the curve is shifted to right and the MCV is 110 or 120 or so on. Another thing is distribution of the red cells. Now, this is very, very important. See here on the left side is the microcytic hypochromic red cells. They are not superimposed upon each other. Look at this one, the normal one. They are very close to each other because here the count is 5 million. Here the count is 3 million. And in macrocytic anemia, in this particular case, the count is probably 1.5 million. Since the red cells are few, so that is why they're widely spaced. So the distribution of the red cells in a smear gives us an idea about the anemia or the degree of anemia in a particular case. Now, this is the red cell distribution width. And what you find here in red cell distribution width, what does it indicate? Actually, RDW just indicates the change, or you say the variation in the size of the red cell or variation in the MCV. Now, the wider it is, this part, that indicates that there are so many cells and each one has got a different size. If the whole curve, if you see the red curve, it is just like this. If that means here the RDW is this much. But here it is almost twice of that. So the RDW is increased or anisocytosis is increased. All right. Now this is just to show you on the left side, you see the shape of the curve is like this, and this field is narrow. On the other hand, this side you find the CV is 34 and you see this curve is very, very wide. The base is very wide. That indicates the RDW. Then we go on to the microcytic hypochromic anemias. Now we know that heme and globin. These are the two things what the hemoglobin is made up of. So are there any abnormalities in the heme also? Yes, there are. These are the porphyrias or any change in the porphyrin. So the sideroblastic anemias belong to this group where there is a defective metabolism in the porphyrin. See about the globin. I told you that globin is a part of the protein synthesis, a part of the protein that is the globin, and this any abnormality is reflected in various hemoglobinopathies, thalassemia, sickle cell disease, E disease, D disease. Or there may be iron, could be the cause. Iron deficiency will lead to iron deficiency anemia. Defective utilization of the iron will lead to anemia of chronic disease or ACD. So what happens in this? In this case, the iron stores are rather increased, but they cannot be utilized because of the problem with the hepsin also. So this is a defective utilization, as a result of which we find that anemia on appearance is microcytic hypochromic, but the stores are rather high. So these are the various causes, and this you can see the central pallor is more than half, not 1/3, but more than half. So this is iron deficiency anemia. And of course, these are the various other causes. This is microcytic hypochromic anemia, and that is reflected in MCH. Now look at this thalassemia trait. Now thalassemia trait is another condition which is quite common in our country, more so north of India, especially Delhi, Punjab, where you find that the thalassemia trait prevalence is quite high. So this is iron deficiency anemia. You will find some pencil cells, which are elongated red cells. You will find the platelets may be high, thrombocytosis can occur. What about thalassemia trait? Thalassemia trait is microcytic hypochromic. Very few target cells may be seen. If you are lucky enough, then you may come across an occasional basophilic stippling in the red cells. So suppose we find microcytic anemia in a child. First thing is check the iron status. If normal, that means then we have to do the electrophoresis and find if the child is suffering from beta thal, HbE disease or HbH disease, or if it is abnormal, if iron deficiency is there or not. If iron deficiency is there, then of course we have to treat the iron deficiency. So this is iron deficiency. And here what we find, MCV is 74, MCH is 22, so both are low. Platelets are increased. So you find thrombocytosis occurs in cases of iron deficiency anemia, and RDW-CV is high. It is 20.8. So what happens in iron deficiency anemia? Are the RBCs like this only, microcytic hypochromic? No. In the first stage, there is just change in the RDW. That means the red cells size variation starts developing. So there is anisocytosis. Next stage, the red cells become smaller. So the microcytosis appears. Third stage, in these microcytes, hypochromia develops. So these are the three stages of development of iron deficiency anemia. And if you happen to do a bone marrow aspirate, then what you find is there is mild erythroid hyperplasia, which you can see. Majority are late normoblasts. They've got pycnotic nuclei. There is persistence of basophilia, and there is fraying of the cytoplasmic borders. Persistent basophilia, fraying of the cytoplasmic border, is a characteristic appearance which is seen in iron deficiency anemia. That is why we always suggest that whenever we do a bone marrow aspirate for whatever disease it may be, we always do an iron stain. But see to it that the slide which we are giving for iron stain also contains marrow fragments. And then you look for iron, no iron in this. You don't find any Prussian blue reaction anywhere. So these iron stores are nil. And in iron deficiency anemia, iron stores are not decreased. Iron stores are nil on bone marrow aspirate. So nil iron stores, micronormoblastic reaction, persistent basophilia, and that is what we have is the iron deficiency anemia. Now target cells. Now target cells are seen in various hemoglobinopathies, whether thalassemia, sickle cell disease, hemoglobin E disease, hemoglobin D disease, and you see here, these are the target cells, central blob of hemoglobin, and then at the periphery. So we find in sickle cell anemias. Then we also find that the red cells are larger, that is macrocytic, and they also show the presence of these target cells. So this happens in liver disease. So whenever we have a case of liver disease, you will come across target cells with some macrocytosis. So this is a microcytic hypochromic, and I showed you the iron deficiency anemia. Now what about this one? Here, what do we find? Here we find MCV is low, 60. MCH is low. And platelets are normal, 244. But what about the red cell count? Look at the red cell count. 5 million, more than 5 million, though the hemoglobin is only 9. So why has it happened? This is not iron deficiency anemia. This is a finding of thalassemia trait. So what do we find in thalassemia trait? Microcytic hypochromic anemia, high red cell count, and hemoglobin is around about 10. But what is diagnostic is, this is HPLC or capillary electrophoresis, where you find HbA2. This curve is 5%. 4 to 8% of HbA2 is diagnostic of thalassemia trait. So usually in thalassemia trait, we don't give iron therapy. How do we differentiate iron deficiency anemia from thalassemia trait? One of the index is Manchester index. If it is less than 13, it is thalassemia trait. If it is more than 13, it is likely to be iron deficiency anemia. So this is microcytic hypochromic anemia, where RDW is more than 25. And you are finding nucleated RBCs, some basophilic stippling, and blue red cell, various shapes and sizes of the red cells. This is thalassemia major. In thalassemia major, anisopoikilocytosis, nucleated red cells, target cells, and some of them may show stippled RBCs also. On the other hand, sickle cell anemia, we diagnose on the peripheral smear. If you examine a smear carefully, you're likely to see these oblong, elongated, and sometimes even sickle-shaped red cells are seen, along with the presence of target cells. Whether it is sickle cell trait, or it is sickle beta thalassemia, or sickle cell anemia that is homozygous, you will in all of them find target cells. However, these sickle cells are clearly seen in sickle cell anemia, but may not be visible in cases of beta sickle thal or in cases of sickle cell trait. Now, this is a typical picture of a case of sickle cell disease. You find target cells are present, normocytic, normochromic red cells, and then these are boat-shaped, elongated cells. And you can confirm it either by doing sickling test, simple test, by having a drop of blood, drop of sodium metabisulfite, 2%, put a cover slip, seal with nail polish. And then you find HPLC, where you are finding this abnormal HBS. HBC is seen in the form of a rhomboid hemoglobin C crystal, uncommon in our country, but of course in Africa you come across hemoglobin C disease. This is thalassemia major. Then we go on to a particular case, 12-year-old with intermittent anemia, spleen is palpable, 4 transfusions. Child is 12 years, but so far only 4 transfusions have been given. Look at the smear, microcytic hypochromic, few target cells are seen. If you ask me, it could be a case of thalassemia intermedia, could be a case of HBE thal, or it could be a case of HBE disease. Microcytic hypochromic target cells. So it was query hemoglobinopathy, query thalassemia. On HPLC, what did we find? See, HPLC showed this is the curve, a very sharp curve before the integration, and not very high abnormal hemoglobin, which was about 8 to 10%. But what did we see in this is the area for HBH disease. Now, what is HBH? HBH is alpha thalassemia. This is an alpha thalassemia with 3 gene deletions. So here we find clearly the reticulocyte preparation. You find golf ball-like cells, these reticulocytes. These are not reticulocytes, but these are golf ball inclusions, what we call the HBH inclusions in a case of alpha thalassemia or HBH disease. Now, you may miss these on cell counters, but reticulocyte preparation will pick up HBH inclusions, it will pick up the Hens bodies, and hence the diagnosis can be made. What is important is, whenever we come across anemia, to know, is there any defect in production, or there is a increased destruction? If there is a defect in production, what is going to happen? The marrow is not forming the red cells, say in aplastic anemia. Then the reticulocyte count goes down. It will be less than 1%, less than 0.1% at times. On the other hand, if it is a hemolytic anemia, that means the destruction is taking place very rapidly. So then the reticulocyte count will go up. So what is needed is, if you want to diagnose anemia properly, the key test is the reticulocyte count. Now, most of the centers do not do reticulocyte count. Neither they do the manual, and the cell counters, they do provide reticulocyte count, but then you have to start in the reticulocyte mode, as a result of which the cost of per test goes up. So many of the centers are not doing as a routine. And this is a simple test, brilliant crescite blue, and you can pick up and know what is the status of the marrow. Is it a defective production, or it is more destruction of the cells? Now, macrocytic anemias, I told you that MCV is high, 110, more than that, folate and B12 deficiency. Now, this is megaloblastic anemia, where we find the red cells are ovalocytic. We call them as macroovalocytic. Then what about non-megaloblastic? Here, it is a normoblastic reaction or a macronormoblastic reaction. And I showed you that it happens in liver disease, it happens in alcoholism, and it also happens in MDS, aplastic anemia. These are all causes of non-megaloblastic bone marrow in macrocytic anemias. Now, this is in the liver disease where you find the target cells, and this is in MDS. Then you also come across reticulocyte response. Now, what are the various inclusions you come across in macrocytic anemias? Cabo rings, basophilic stippling, Howell-Jolly body, hypersegmented neutrophils. And then look at these red cells. They are egg-shaped. These are macrovalocytes. They're large, and then these are egg-shaped macrovalocytic anemia. These are all features of dyserythropoiesis which we come across. Now, if you do the bone marrow, you find megaloblastic. And what do you find here? Look at these two late megaloblasts. Late megaloblasts, the nuclear chromatin is open, but sieve-like nuclear chromatin, but look at the shape. It is not round. This is a dumbbell shape. Again, it is not round. Now, that is a feature what we call as these cells are showing dyserythropoiesis. This is dyserythropoiesis, when the shape of the nucleus is abnormal. And you will find some inclusions here and there, Howell-Jolly body, stippling, Pappenheimer bodies, Cabo ring. And then in the exam, the examiners give you a smear and say smear for comment. And what does this smear show? See here. You will find large number of target cells, good number of target cells. You usually don't come across as many target cells except in hemoglobin C disease. Second, you are finding Howell-Jolly bodies in many cells. You are finding many target cells. You are finding many fragmented red cells. There are clumps of platelets, large number of these nucleated RBCs. Now, these are all features of post-splenectomy smear. Now, it may be accidental splenectomy or surgical splenectomy, but these are all the findings which you come across in a case of a post-splenectomy smear. And these, of course, are the Howell-Jolly body. Now, this very case, since there is a sickle cells lying around, this is a case of autosplenectomy. What has happened in autosplenectomy is we teach our undergraduates that because the sickle cells, they block the tiny capillaries, necrosis of the spleen occurs. As a result of necrosis, the spleen stops functioning. It becomes a fibrous tissue only, and the patient behaves as if there is no spleen. So it is something like autosplenectomy or postsplenectomy. Now, dimorphic anemia is combinations of, when we say dimorphic, usually what we mean is two different populations of the red cells. In our country, macrocytes with microcytes is common because we have multiple deficiency anemias, B12, folate, iron deficiency anemias. But then dimorphic population can also be seen. Suppose it is a macrocytic anemia and you have given a transfusion, then what is going to happen? The smear will show two populations. If it is a iron deficiency anemia, microcytic hypochromic with normal cells, normocytes, again, it will give a dimorphic picture. So you should know what is the cause, and then response to iron or B12 therapy. That means we have a case of B12 deficiency. You have given B12 injection. So after 1 week, what you find is that there is a reticulocyte response. After 5 days, reticulocyte response occurs. And in reticulocyte response, large number of reticulocytes come into the peripheral blood, which are larger, and they are polychromatophils. And therefore, you find a dimorphic picture. Normocytic, normochromic anemias. Now, this we go on to, I'll show you just 3-4 cases and finish off in about 5 minutes. What do we find here? 58 years old lady, pallor, abnormal high MCH and MCHC with macrocytosis. See here. MCV is 130, MCH is 87, unheard of. MCHC is 67. Platelets are tremendous, 406. Cause unknown, spuriously high WBC and disproportionately everything. So what do you find in the peripheral smear? Look at these. These are agglutinates. These are red cell agglutinates. Why the red cells have agglutinates occurred? Because this patient has got IgM in her blood. Where from this IgM has come? She had non-Hodgkin's lymphoma. There is secretion of IgM in some of the non-Hodgkin's lymphoma that leads to agglutination. So this is agglutination of the RBCs which has occurred. So this is cold agglutinin disease. That if you try to make a smear out of this blood, it is rather difficult because as you try to make a smear, there are these agglutinates of the red cells are present. But if you warm it, then what happens is 37 degrees centigrade, you can easily do the red cell counts, you can make a smear and examine it. So this has to be differentiated from rouleau formation. This is a case of multiple myeloma. Now what you find the difference is that these are agglutinates, clumps. On the other hand, in the rouleau formation, they are like coins in a stack. You find that is how the difference occurs. Here also you will find MCH high, MCHC high, MCV high. So you have to make the smear to see what are you dealing with. Are you dealing with the case of hypergammaglobulinemia? Now this used to be seen in the peripheral smear. When I joined MBBS during MD, what we found was that in a smear of peripheral smear, we'll find this picture of rouleau formation. So we thought these are all cases of multiple myeloma, but no, these were not cases of multiple myeloma. What we used to do was take a drop of serum, put in a drop of formalin, and it would become like the white of an egg. It will just become gelatinous. These were the cases of Kala Azar, in which there was hypergammaglobulinemia, and that used to clot by putting a drop of formalin. Of course, now Kala Azar has decreased in our country. So this is cold agglutinin disease. This is a rouleau formation which you find in a case of multiple myeloma or Kala Azar. Now, looking at the smear, what you find here is fragments of red cells, triangular cells. Then these are the hat-shaped cells. Again, fragmented red cells. Now, these are all fragmented red cells, valve prosthesis. See, when we were doing MD, there used to be the plastic mitral valve replacement. The valves were not so well defined. So plastic ones were available initially. So what used to happen was you replace the mitral valve, and then what would happen is that plastic, as the blood would fall on these valves, the red cells would fragment. And that is what would happen in the peripheral smear. So if you are aware of this condition, and if the surgery has occurred, heart surgery in a patient, even a stenosed valve can lead to this kind of picture. Of course, now we know there are so many causes, especially the angiopathies, what we call as microangiopathies. There could be DIC, there could be TTP, there could be hemolytic uremic syndrome, and valve prosthesis can give rise to fragmentation syndrome. These are all fragmentation syndrome. Helmet cells, triangular erythrocytes, spherocytes, and these are the fragmented red cells. Spur cells I showed you in a case of, now this is another case I want to show you. 72 years old lady admitted with weakness and pallor, 5 years, spleen was stiff. Thought it is a deficiency anemia, but no, it wasn't. Hemoglobin was 7, hematocrit 23, microcytic hypochromic, platelets were slightly more, and dimorphic picture. Not responding to treatment. Dimorphic anemia, but refractory. So we advised a bone marrow since it was a refractory anemia. Look at the erythroid hyperplasia. In most of the anemias, that is how the marrow responds to compensate for anemia. Iron stain must be done. So iron stores were slightly increased, grade 4 out of 0 to 6. What we find in oil emulsion is, look at these erythroblasts. They are showing you rings of blue siderotic granules in the erythroblast. Ring sideroblast is a diagnostic feature of sideroblastic anemias. And lastly, a word about the leukoerythroblastic blood picture. What is leukoerythroblastic? So that means you find immature leukocytes, you find immature erythroblasts, metamyelocytes, nucleated RBCs, and this occurs usually if there is extramedullary hematopoiesis or marrow fibrosis, myelofibrosis, osteopetrosis, severe hemolytic disease. Now, this is a case of primary myelofibrosis, that is what is in the marrow. Both are biopsies. Here again, there is marrow fibrosis, but there it is metastatic deposit and desmoplastic reaction. So what are these teardrop cells? Now that is what you find, that these are the teardrop cells which are seen, teardrop cells, and you find nucleated RBCs, metamyelocytes. So these are the two conditions. Whenever now we come across leukoerythroblastic blood picture, we know that marrow fibrosis is there. So there is no point in attempting an aspirate. We should always do a bone marrow biopsy. Now, this is actually a flow chart, but I'm not going into the details. I'll read up 3 words for you. Anemia, they couldn't diagnose, flow chart, everything. Ultimately, what do they want? CDA gene panel. Then here we find suspected of enzymopathy. Now here, what do we find? They've suggested RBC enzymopathy gene panel. Here we find that consider CDA registries. Here it is written globin gene sequencing. Now what I mean is, so far the progress had been made in malignancies, leukemias, lymphomas. We were going after the gene alterations. We were going to find out the various gene sequencing, what is happening, and myelodysplastic syndromes, and diagnose the disease. But now panels have come, gene panels have come for red cell disorders, for membranopathies, for membranopathies, for enzymopathies, and for diagnosis of various hemoglobinopathies also. Lastly, a case of pure red cell aplasia, child admitted with pallor. What you find? Red cells have disappeared. Precursors are not there. Myeloid cells plus megakaryocyte. But whatever we found were the giant proerythroblasts. I had mentioned that in sickle cell disease, in hereditary spherocytosis, we teach our undergraduates that aplastic crisis can occur. Now that is because of parvovirus B19, which gives rise to giant proerythroblasts, but otherwise erythroblasts disappear. Now we know that whenever there is immunosuppression, we know nowadays a lot of immunosuppressives are being taken by various patients, and in them you find that the parvovirus B19 may infect, resulting in, this is a typical giant proerythroblast with the cytoplasmic projections. This is on bone marrow refined biopsy. Thank you very much. And any questions, comments are most welcome.
Well, good evening, sir. I think it was a very, very highly informative information. I'm sure all of us and a lot of people logged in, they have really, I mean, probably everything is revised in probably in one lecture. And I think we probably miss out many things when we do our microscopic studies. But I think this will definitely a good reminder, like let's go back to the microscope and see basic simple thing, a red cell actually or a WBC can actually give you a lot of information. I have one question has come in the box. I think anybody else, if you have any questions, please send across. We'll request her to answer that. This question is from Dr. Reshma has sent this. For iron deficiency anemia, which test is not diagnostic, whether ferritin or serum iron levels?
Ferritin is diagnostic. but serum iron level is not diagnostic. On the other hand, it is better to do the transferrin saturation. If transferrin saturation is less than 15 or 16, it is highly suggestive of iron deficiency anemia. But serum ferritin is a far better test to assess the iron stores.
Okay, Dr. Reshma, I hope this answers your question. I have a next question from Dr. Ashima. This is is a good reference or anything for a book for Indian standards of RBC indices? Because Western is probably there, but Indian probably they have been asking for.
There is one book on cell counters, how to interpret by Professor from Jabalpur. Next time I will tell you his name. He has been Vice Chancellor of Madhya Pradesh University also. And he has written a very nice small book. It is a pocket book on Dr. Lokwani, Professor Lokwani. It is a very nice book, Indian book, and costing nothing. So that book can be read.
Okay, I hope that answers the question of Dr. Ashima. And we have next question from Dr. Nidhi, sir. Would a clinical exome decide on any hereditary anemia, sir?
Again, question again.
Would a clinical exome panel decide on any hereditary anemia?
See, hereditary anemia, the panels actually for various gene panels have come up, and this is a sort of a recent thing. With NGS coming into most of the diagnosis, now only these NGS panels have been devised for red cell disorders. But except for the few of these ones, others diagnosis can be made on peripheral smear, bone marrow aspirate, and simple tests like CDA, type 1, type 2, type 3 can be made out basically on morphology. Depending upon whether we are having dumbbell-shaped erythroblasts, we are having binucleated erythroblasts, or multinucleated erythroblasts. So maybe no, clinical does not decide. It is the morphology of the erythroblasts which is the decisive factor in such cases.
Okay, I think definitely. I think that hopes that addresses your question. Then we have Dr. Kiran Jose asking, what happens to red cell protoporphyrin levels in iron deficiency anemia?
See, the protoporphyrin is normal in iron deficiency anemia. However, the sites for the iron attachment are empty. Since those sites are empty, so the heme is not formed. Since the heme is not formed, so there is no iron. Now we know very well that the early erythroblasts have got a blue cytoplasm due to RNA. That is why that cytoplasm is not getting hemoglobinized. Because it is not getting hemoglobinized, so the erythroblasts, they still remain basophilic right up to the late normoblast stage. That is why I told the two distinctive features: persistent basophilia of the normoblast and fraying of the cytoplasmic borders. So there is no defect in the protoporphyrin. Defect is lack of iron elements.
Okay. Dr. Kiran, I hope that addresses your question. We have, I think, follow-up question from Dr. Reshma again, sir. In some microcytic hyperchromic anemia cases, serum iron is low with high ferritin, with HPLC normal. Is it also iron deficiency anemia?
See, with HPLC being normal indicates that there is no hemoglobinopathy, including thalassemia trait is not there. High serum ferritin is an indicator of a chronic or an acute inflammation somewhere in the body. So it then becomes an anemia of chronic disease, ACD, what I told, in which you find that the serum ferritin is high, the hepcidin level goes up or goes down depending upon the liver function. And those are the cases in which you will find that the iron is present in the form of ferritin, but is not being utilized. It is not available for utilization.
yes, I think in any case, let's look back for the next session, which is on 15th of May. That's a peripheral blood smear demystified. That's going to be probably whatever questions are remaining. I'm sure you can all gather and get back to the sir again, and I'm sure he'll be glad to answer that. With this, I like to end this session, and it was thank you everyone for a great, and thank you to Inder Singh sir. I think as ever, and of course, Dr. Veena Kohli ji. And in any case, I like to end with something which is probably you can take home. I think whatever you're taken home is a lot from sir, but I am probably a different note. But in any case, in the delicate, in our life, there's a peripheral smear, the hidden information within the simplicity of the peripheral blood smear. It's not just a clinical test. We have learned that each droplet of blood tells a story, whispers the secret of health and vitality. Now, as we see through the lens of microscope, we witness the intricate harmony of the cells, how they balance the balance, each one a proof to the miracle of life itself. In each drop, a universe unfolds, revealing life's intricate canvas in its simplest form. Just as in life, whether the smallest gesture can hold the most significance, so does the examination of peripheral blood. It teaches us the importance of paying attention to details and finding value in the seemingly simple things. And with that, I narrate, let me drop down. I didn't know how to end that, so I probably wrote down a couple of lines, couple of minutes back, which says, let me read it out for you, all of you guys. रंग बरंगी ब्लड सेल्स ने हमारी दुनिया को है पहचाना, हर ड्रॉप ऑफ ब्लड कहती है जिंदगी का अफसाना। आज हमने डॉक्टर टी सिंह सर की जुबानी सीखा, लाल नीले सफेद से सब कहते हैं अपनी कहानी। हर सेल्स की है अलग अलग शक्ल, हर एक सेल में छुपी है जिंदगी की असल झलक। हर सेल का है अपना असर, ये सेल्स में भरा है जिंदगी का सफर। Thank you so much for everybody. It was a wonderful talking to you guys, and I think I look forward. Thank you, Vanguard. Thank you, Unipath, and thank you, sir. And Veena ji, hand over back to you.
Thank you so much at the outset, Dr. Gaur, for moderating this session in your signature style, and how you are able to add an element of poetry each time is incredible. And I can see a lot of claps coming up that are all very, very well deserved. It's so enjoyable, and thank you so much. And of course, I really want to thank Dr. Singh, our sir, for such a mesmerizing session today, and for explaining to us so beautifully and simply the relevance and importance of peripheral blood smear, despite the extraordinary advances that have taken place in the automated hematology analyzers. And I'm sure everyone will agree that the RBC part of the peripheral blood smear has been demystified without a shade of doubt by sir. And we look forward to the WBC and platelet parts getting demystified during the next session. So thank you all. Lastly, and most importantly, all the attendees who joined us in very large numbers. So please block your calendars for Wednesday, the 15th of May, 3 to 4 p.m., same time, for another session, the second sequel of this topic on peripheral blood smear, where Dr. Singh will cover the WBCs, which are the most complex part of blood, and platelets. So stay safe, happy, healthy till that time, and wonderful being connected with you today. Thank you very much indeed. Thank you.
Thank you, everyone. Bye-bye.